Thank you a lot to everyone. And please, next slide. I will talk to you about work I do with some colleagues in University of Sao Paulo about AIDS and disease having a distinct influence on postural balancing of patients with COPD. So this is a published paper, and here on the QR code, you can have the access for the full version of the paper. Please, next slide. First of all, we know that COPD is a pulmonary first disease, but it has some extrapulmonary features that are involved in COPD, like inflammation and weight of loss, and some postural balance problems. Please, next slide. Postural balance problems that are involved in COPD can change the ability to maintain posture in COPD. And we have the importance about this kind of problem involve respiratory and pulmonary function, creating dysfunctional aspects that can involve for the poor respiratory function and pulmonary function. Please, next slide. The principal impairments that we can see on postural balance in COPD is impairment of postural control, reduced functional capacity, and this because of the poor synergy muscular that can involve trunk and thorax, and this can reduce the ability of contraction about diaphragm and abdominal muscles. We have low independence during daily tasks that are involved with postural balance, and not only about the difficulties that are involved in the respiratory function. And we have increased risk of fall. These patients has a sensory motor demands that are most deficits that can reduce their capacity for functional, like walk and maintain postural balance in bipedestal posture or orthostatic posture, and some difficulties in changing postures, like from sitting to stand. Next slide, please. So we have in the literature some mechanisms that we can assess postural balance with some security. One of that is computerized dynamic posturography. And we have here the importance of this test that can assess the sensory components of postural balancing, using for that sensory organization tests sought, and about motor components that are involved in the control of center of pressure and center of gravity body. This is the goal mechanism to assess postural balance. Next slide, please. We have another problem about postural balance, that is aging. Aging can diminish sensory systems, feedback, and central integration, as well as motor system capacity for postural balance. This is important, and this is marked, this is a component about loss of cells and loss of reduction of function of some cells. In particular, about somatosensory system, vestibular system, and visual system. And this can uh, lead to a postural balance deficits. We have for that SOT and MSOT, that is Modified Sensory Organization Test, recommended for older adults in evaluating postural balance. Please, next slide. So for that, our study have the hypothesis that aging as well as disease have an influence on postural balance in individuals with COPD. We have the aim for characterizing this condition, and for that we need to assess the postural balance in COPD patients that have some age aspects. These findings are important for the development of new therapeutic approaches concerning the ability of patients to prevent the risk of falls during daily and physical activities. So we try to understand about the influence of age and disease in postural balances in patients with COPD, evaluating for that sensory and motor components. Next slide, please. So we have for that, our study was designed in a transversal version, and we have for that three groups of patients. COPD group that has age importance about 50 years old to 85 years old. We have an older health group, age and sex matched, and we have younger health groups that has only sex matches with the COPD group. We have for each group 30 participants that were assessed in the posturography control assessment. Please, next slide. Our inclusion criteria has the importance about the patients with COPD be stable and in medical treatment at least the last 6 months. They range about 50 to 85 years of age, and post-bronchodilator forced respiratory volume, FEV1, less than 80%, and of predictive FEV1 and forced vital capacity about less than 0.7 in the COPD group. For inclusion criteria, we have most the importance of patients that are have independence in the daily lives and can stand on about 5 minutes. We have also for the inclusion criteria no musculoskeletal group features, no sensory impairments, no vision impairments, and no vestibular impairments. So we need to stay with the patients being the most importance of each physical capacity. Please, next slide. For that, we have to assess the clinical data of all the patients. And we have for that two principles, variables. We have done in the patients and in the control groups modified sensory organization test that consists on maintaining quiet stance over a forced platform in 1 minute, during 1 minute. We assess for that balance stability on postural sway in a Cartesian plan. And for that, we manipulate, we weight sensorial conditions, using for that some difference in the surface and on vision. For that, we have fixed and sway heaven surface and full vision and no vision for the patients. We assess on that kinetic measures about linear dysfunction in COP, that is center of pressure. We use amplitude, mean velocity, and root mean square to assess the importance of the quiet stance control for the patients. We have that another variable that is load asymmetry that could show us where the center of pressure of the patients and control groups are positioned. Please, next slide. This is the SOT and MSOT evaluation. We have for that 6 conditions. In our template, we have condition 1, 2, 4, and 5. We don't use condition 3 and 6. For that, in the quiet stance, patients stay on a forced platform and controls stay on a forced platform using for condition 1, fixes surface and full vision. And for that, we have all sensory systems allowed to maintain balance. In condition 2, we ask for the patients to close their eyes, and we have for that on proprioceptive and vestibular systems applying to postural balance. Condition 4, we have the sway reference, and this damaged a little the proprioceptive, the somatosensory information, and the patient stays in postural balance because of the vision and vestibular system. And we have closed the eyes in the sway reference surface, and for that, only vestibular system can stay entering and allowing the postural balance. For that, we compare the postural balance with an inverted pendulum model that can show us that the patient is oscillating, swaying more or less, and we're in the first platform. Please, next slide. We have our analysis. We do a three-way ANOVA that use for that importance of groups, surfaces, and conditions of vision, and a post hoc comparison through Newman-Kuhn procedures. The level of significance was set on 5%. We use a criteria to evaluate age influence and disease influence. For age influence, we consider a difference between either older health or patients with COPD compared with younger health adults, but without difference between COPD and older health adults. And we have disease influence criteria that consider a difference between COPD and older health groups. Please, next slide. Here we have a resume, a summary about the clinical data of our patients, and see that COPD and health adults have no difference about age and features as height and weight. And we have a young group with early age, and this is our importance. We only assess respiratory features in COPD group, and this can show that they have some impairment from from poor to moderate, and we have importance that these patients are stable clinical in a clinical way. Please, next slide. Here you can see the raw data about the center of pressure in the conditions, in the 4 conditions evaluated. On the top, in the 3 groups, we have the conditions of fixed surveys with vision and no vision. And in the bottom, we have the conditions of sway surface with vision and no vision. The first group on the left is COPD. And if you can see, the raw data shows a greater sway in this group. So we did some some statistical analysis to compare this data. Please, next slide. Here we can see that the group's difference is statistically significant, and in most of all, they show difference in the sway surface. That are the surface that evaluate vision and vestibular system. The principal features that difference the groups were observed in the anterior posterior, that shows us a greater sway for the COPD group, and a less sway for the younger group, with the old group in the middle of that. We can see this importance in the amplitude, in the velocity, and in the root mean square. That is important for us to understand about the risk of fall in these patients. Please, next slide. We could see also that the patients with COPD has a forward position of the center of pressure, comparing that with the older and younger group that has the less forward center of pressure position in the platform. This is important, that this can lead to a risk of fall greater in the COPD group, and a higher mechanical motor demand for the patients with COPD. So this difference in the position of the center of pressure has an age and a disease influence. And we could see this about our kinetic measures. Please, next slide. Thank you. You can see here that for age influence, the most important difference was on amplitude anterior-posterior, root mean square anterior-posterior and medial-lateral, velocity anterior-posterior and medial-lateral, and ASI, that is load asymmetry. This is important that age can vary postural balance. In this kind, our data show that age lead to a higher amplitude, higher velocity, and a higher difference on the position of the center of pressure. But we could see also a disease effect. And this disease effect was observed in the amplitude, anterior-posterior amplitude, in the mean velocity, in the anterior-posterior amplitude, in the posterior, in the load asymmetry, in the anterior-posterior position. So disease effect in the COPD group could also lead to a higher amplitude, higher velocity, and more forward center of pressure position. Next slide, please. Thank you. What we could see is that COP, center of pressure excursion, was faster with higher amplitude and variability progressively from patients with COPD, older health adults, and younger health adults. And disease influence were observed in COPD patients and characterized as sensory motor deficits for postural balance in these patients. And that is important, and we need to understand that for more applicable therapeutic approaches to serve these patients. Center of pressure forward projection in COPD patients can be related to hyperinflation and thoracolumbar spine hypomobility that can difficult the functional and motor capacity of these patients, and this can lead to a difficult in the postural control of these patients. We could see also that posture influences respiratory function, including abdominal muscle synergy with diaphragm. And this is important that this can lead to less respiratory and pulmonary function in these patients. And we have the importance of vestibular sensory motor components that can be damaged in these patients also, like the vestibular respiratory reflex. And this can lead to a less importance of the respiratory function. And we need to see this to lead to better approaches in these patients. Please, next slide. We have limitations in our study. The standard generalization of our results is limited by the fact that the surface of our posturography only can have movements in the anterior posterior direction. So we need to investigate better the mediolateral oscillations. The pulmonary function was not assessed in the health group, younger and older. However, all of them had no signs of respiratory dysfunction in the clinician's regular exams and no complaints of respiratory function. But we needed to correct this in next studies for a better approach. Please, next slide. For our final considerations, we can see that postural balance can enhance treatment and be beneficial for these patients. Seeing for that sensory motor components treatments and exercise. It must be considered that beyond challenging postural control in patients that is important with COPD, it is needed to improve capacities of and sensory motor strategies. And for that, the treatment approach should be designed as progressive as possible, but simultaneously with safety regarding postural stability and not only challenging. And we need to see physical demands and respiratory function in all times for these patients. Next slide, please. In conclusion, we have that medial lateral imbalance in patients with COPD is reduced and has an important age influence. And the anterior posterior imbalance observed in these patients is reduced to both age and disease influence. These results strongly suggest that impaired postural control is presented in patients with COPD and is more relevant when compared to healthy individuals older than 50 years of age. And this needs our attention for patients with COPD with a better sensory motor approach in the treatments. Next slide. That's our references. Next, please. And next. That's okay. For now, I would like to thank you and apologize for some contratemps, some features that could involve. In this QR code, you have the access for our paper, and this can help our approaches with patients with COPD. Thank you a lot. Thank you.